Hi, I'm Tamara Thomas, Editor-in-Chief for Urban Health Today, and I'm speaking with Dr. Michelle S. Williams, Assistant Professor of the Department of Global and Community Health at George Mason University's College of Health and Human Services. She's here to talk about African-American breast cancer survivors who are at high risk for cardiovascular disease, but have low knowledge of this risk or the signs of a cardiovascular disease. Thank you for speaking with me today, Dr. Williams.
Well, thank you for inviting me.
Let's get started. So can you walk me through your research? How did you learn that Black women in the Deep South had this this knowledge gap, this challenge?
Well, my research interest has been focusing on improving the health outcomes of African-American breast cancer survivors overall. And originally, my main interest is in obesity and cancer outcomes and how closely they're linked. But in 2018, the American Heart Association actually put out a call for more research looking into the intersection of breast cancer and cardiovascular disease, because what they're seeing is that breast cancer survivors tend to have an increased risk of death from cardiovascular disease. And when we look at data for African-American women who have had a history of breast cancer, we do see that they tend to have a higher mortality rate because of cardiovascular disease, even at earlier stages of breast cancer diagnosis. So that's why I'm interested in looking at what we can do to help to decrease the risk for cardiovascular disease in this population.
So I know that your studies focuses on the Deep South, but have you found a wider pattern of this low knowledge on the cardiovascular disease?
Well, my research has only been focused on the Deep South and women living in the Deep South states. But I mean, I don't like to make extrapolations to Black women and other populations, but I do think that overall in the US, cardiovascular disease knowledge about risk factors and even symptoms is relatively low.
Yeah, can I just share with you? I'm a pretty well-informed woman, and I didn't know even that surviving breast cancer puts you at higher risk for cardiovascular disease. When I first heard that, I was like, what? Why? Okay, so that takes us to our next question. Why are breast cancer survivors at high risk for cardiovascular disease?
Oh, that's a great question. So when we look at the risk factors for breast cancer and we look at the risk factors for cardiovascular disease, there is some overlap in preventable factors, such as obesity is associated with the increased risk of CVD and breast cancer, as well as other types of modifiable health issues. And so that's one factor in terms of increased risk, because we do see these overlaps in risk factors. But then we also know that there are certain types of treatments that may be cardiotoxic, meaning that it can have effects on the cardiovascular system. So for example, radiation on the left side where the heart is, or also certain types of chemotherapy can be cardiotoxic. And therefore, women who've had these treatments would also be at increased risk because of the damage to their cardiovascular system from these treatments.
Wow. What did you find were reasons why cardiovascular knowledge was so low among the study participants?
Well, I think one of the main things, because what the research that's being reported in that article was specifically focused on the questionnaires that I administered, but there was another part of the study where I also did interviews with a subset of the participants. And so I actually asked the question, did your doctor tell you that you may be at increased risk of cardiovascular disease? And the majority of the participants said no, their healthcare provider had not informed them that, again, there are certain risk factors, modifiable risk factors associated with breast cancer. And then there's also these other factors regarding treatment that can increase the risk of cardiovascular disease as well. The majority of the women said that they just had not heard about that from their healthcare provider.
So in other words, you are at higher risk, but it's not a death knell because of the fact that the risks are modifiable. Like this is preventable. It's not a life sentence, right?
Right. So a lot of the factors are modifiable because it has to do with things like I mentioned, lack of exercise, obesity, your eating habits, as well as stress, which can be modifiable as well.
Why will there be a rise in the number of breast cancer survivors with cardiovascular disease?
Well, it's kind of like this double-edged sword. So we know that overall breast cancer mortality is decreasing, meaning that women are living longer with breast cancer or having survived breast cancer. However, there are all these other comorbidities that are going to come in and cause the other issues. So that's one of the factors associated with the increase in CVD, because we are going to see survivors living longer because of the breast cancer, but then they have this increased risk of cardiovascular disease that can come in and cause the premature mortality.
Can you talk a little bit about CHIP's lack of success reaching Black, rural, and underserved communities?
Yes, so the Complete Health Improvement Program is a phenomenal program that has been shown to be very highly effective at reducing cardiovascular disease risk factors. And I had the awesome opportunity to speak with the founder of CHIP, Dr. Hans Deal. And I asked him about the implementing CHIP in predominantly African-American communities and also communities in like rural areas in the US. And he was just very honest with me and saying that he knows that the program has not really been successful in those populations. He mentioned he himself had tried to implement it in a predominantly African-American community, and it just didn't go over very well. And so I think one of the problems is that it's not really culturally appropriate. And so that's where my work comes in, is how can we make it more culturally appropriate in terms of not only the types of foods that are being introduced through this program, but also just the images that are implemented in the program. So for example, like I mentioned, another part of my research was I actually showed breast cancer survivors a clip from the CHIP video. And I asked them from their feedback, and the majority of them were like, well, I don't feel like this was talking to me because I didn't see enough people who looked like me in this video.
Oh, okay.
Right. And so I think that's one of the things that you have to really consider, because research has shown that, pretty much any intervention for weight loss or health improvement will work if you do it. But the problem is really engaging people in that. And for African-American women, the research has shown that when you have these generic programs that, are really applicable, widely applicable, they don't tend to be as successful as when you have programs that are really tailored towards African-American women, meaning you see African-American women in the examples, you even see African-American women as people who are the educators in the program.
Okay, all right. So poor diet and BMI, body mass index over 30, were significantly associated with higher risk for heart disease. Mm-hmm. Given this data, how do you envision healthcare professionals engage? Like how do you envision them engaging patients in modifying their risk factors like diet and physical activity? I would think that, and I could be wrong, but I would think that in light of this data, there would be more coordination between, say, ASCO and AHA for like intervention efforts. What are your thoughts on that?
Yeah, absolutely. I definitely think there needs to be more integration because, as I mentioned, the American Heart Association has called for more work in this area, but it takes so much time to actually reach the level of implementation or the level where the provider has the awareness and the knowledge about this. And so another aspect of that is I think sometimes that providers are just overburdened because there's so much that has to go into a very short office visit with a provider. Then that's where I think a lot of other types of ancillary healthcare providers or ancillary people working in the healthcare field can come in. So for example, if a healthcare provider sees that they have African-American breast cancer survivor who is clinically obese, then they can write them a prescription for a nutritionist, or write them a prescription to go see an exercise physiologist who can help to develop an exercise program that will really fit their needs. We really don't see exercise prescriptions like that, but those are things that are needed. And I think that working necessarily with these other entities would be very helpful.
Do you think a similar study should be done for Hispanic or Latino women? Is there one?
Not to my knowledge, but absolutely, absolutely. I definitely think there is a need to do work in all racial and ethnic groups because, I hate to say this, but a lot of times when we think about obesity, we probably may really think about like African-American women, but there are obese women in every racial and ethnic group that could definitely benefit from this information. And it's not necessarily biological that Black women have this increased risk for cardiovascular disease if they have a history of breast cancer, right? So I definitely think that it needs to be in other racial ethnic groups as well.
So one thing you said in your study comments was that breast cancer survivors must be better informed about CVD risks by their healthcare providers. So in your view, what needs to happen in the patient care continuum to better inform patients? Who should be responsible? Who should educate? Let me just give you an example. So I think I already told you that my mom passed away from metastatic breast cancer several years ago. And I also carry the BRCA2 gene mutation. So I see my breast oncologist for surveillance. Every 6 months I see her. And every time I see her, she brings up prophylactic surgery for my ovaries. And then when I start to engage her in the conversation, she says, well, talk to your gynecologist. I'm not a gynecologist. But she's the one that brought it up. So, and my gynecologist doesn't talk about this with me. Like, why is it my responsibility to, and I don't mind doing it, but, I could imagine where a patient feels like, well, why is this my responsibility to, and I realize that the patient is supposed to be their own advocate in a number of ways. But I think a lot of people in general just feel so put upon. I remember the first time when I first found out, my genetic test came back positive for the mutation. And I went to see the first oncologist. I cried in that because he was just throwing so many things at me. Immediately it was like, do you want to remove your breast? We can schedule it now. And I'm like, no, they're still healthy. How about we take out your ovaries? How about we do this? How about we, and I just started crying. And I'm not a person that's moved to tears very easily. But the whole thing I found for me was very overwhelming. And I'm not a shrinking violet in the least. Like I'm very proactive. I'm very, pro, asking questions and researching, taking care of myself and pushing back if something doesn't sound right to me. But I broke down and I cried in that because it was just so much. And I just can't imagine other patients not going through something similar and maybe not having that force of pushing back or being your own advocate. So whose responsibility is it to coordinate these efforts?
That's a good question. That's a good question and a dilemma that a lot of people go through. And apparently, it's not a nationwide standard, but a lot of cancer centers do have cancer navigators who are basically trained educators who have this additional knowledge about cancer, and they can help people navigate the system. So they would be able to answer questions that you may have about that, and then refer you back to other people, or even provide resources that can say, these are the questions you need to ask your healthcare provider, because like your oncologist said, go ask your gynecologist, but you might not know the specific questions to ask your gynecologist. But there are these tools that are out there, that, again, the cancer navigators are very good people to work with in this arena. And I just wish that they were more commonly used. I know that where I did my predoctoral training at the University of Alabama, Birmingham, we have a comprehensive cancer center that has a suite of cancer navigators who that is their job, to work with people like yourselves who have these questions and how to navigate through the whole journey of cancer even before a diagnosis.
And so I ended up switching breast oncologist because I just felt that he was a little too intense. And so I ended up switching to a woman in another hospital. But again, that was me sort of taking matters into my own hands. And I don't even have cancer. So you see, so now just imagine you had cancer, you survived this horrible ordeal. And then now it's like, now what? Okay, I've survived and I've got to try to not get cancer again. I've got to stay alive for my family, for my community, whatever. I'm just, and this is not something that's standard across the US, you're saying? This. So what does a patient do? What can patients do? How do patients empower themselves?
That's a good question. I, for a very long time, was a part of Susan G. Komen in North Central Alabama. And we recently closed our office. But there are plenty of community-based organizations. And I think that those are a great resource for people. You know, a lot of times we see these organizations raising money, but organizations like the one that I was a part of, they actually have amazing support groups where women can talk. And, you know, sometimes that's your best source. If someone's already been through that, they can help another person, right? Also, like, one of the things that I did was I would organize lunch and learns with specialists who people wouldn't necessarily have access to on a regular basis. For example, I organized this one lunch and learn where it was one of the most popular ones that we had, where we had physical therapists come in and talk about lymphangioma, which is very common in women survivors who've had their lymph nodes removed. They have extra fluid building up, and you know, they just did not have access to that information. So now they have a better understanding of how to treat their lymphangioma. So I say all that to say there are still a lot of community-based organizations out there, especially the ones that are run by survivors themselves, who really understand what survivors need. And they can provide those additional resources for survivors. And also, like you talked about, you know, being your own advocate, they can talk about how to advocate for yourself and to be an advocate.
So what's the next step in your research? Where do you go with this information? What's next?
So I'm currently in the process of getting another aspect of this study started. So like a part 2 of this study, where I'm actually going to be collecting more in-depth details about survivors' risk factors. So I'm actually going to be measuring BMI. I'm actually going to be measuring blood pressure and things of that nature. And one of the things with this particular study that I'm starting now is I'm doing a case control study where I'm looking to see, are the risk factors in African-American breast cancer survivors really high, much higher than women who have not had a history of breast cancer survivors? So I'm going to be enrolling both women with and without a history of breast cancer so that we can see whether or not there are these modifiable risk factors that are really much higher. Because I think a lot of researchers are saying, well, African American in general have, you know, just worse health outcomes. But my whole hypothesis is that it's even worse in African American women with a history of breast cancer. So that's what the next aspect of the study is. But then I'm also working on studies trying to implement breast cancer education interventions in the time of COVID pandemic, and how can we do this and get women engaged in breast cancer education without being in person. Like I mentioned, I used to do these lunch and learns, but now I'm like, well, how can we do this virtually? So that's another project that I'm working on right now.
Wow. Well, you know, Dr. Williams, I hope you'll come back, you know, please, and, you know, and let me know how the second phase of, you know, your study is doing. And I thank you so much, you know, for your time today. I really appreciate it. I really appreciate having this discussion with you.
Well, thank you. And thank you again for inviting me. I really appreciate it.
Thank you.